So I'm going to speak about an update on experimental controls in clinical research on acupuncture. First of all, let's take a look at the context. It's a very important context of clinical research. Acupuncture does not easily fit into a model of pharmacological clinical investigation based on randomized placebo-controlled trials, as it's currently known by everybody here. However, information derived from the RCTs on acupuncture rapidly grows, requiring understanding of its true scope. So we need to understand this context and to get to the conclusion of what we really get from all those studies in order to improve our knowledge and our practice. So the problematization here is, in order to reconcile acupuncture and current clinical research, we have to look very carefully at the several problems that arise from this tension, this conflict between a practice that does not fit completely into the RCT model and at the same time, this requirement of validation. So I'm going to discuss several problems that arise from this tension. The first problem is acupuncture is a procedure. Implications of that is acupuncture has a specific psychosocial space-time context that's very particular of acupuncture. All the environment, all the ritual, everything that surrounds an acupuncture session that is not specific of acupuncture treatment in terms of physiological effect, but it's part of the whole thing. And at the same time, acupuncture is provided by an external agent because it's a procedure. And this agent is very particular. It's the interaction between this agent and the patient, the therapist and the patient is a very important part of the treatment. So we have to be aware that acupuncture involves a whole ritual, and this ritual clearly affects the kind of results we get, not only in the day-by-day practice, but of course, deeply the results we get from research. Such an agent, this agent that applies the treatment, will hardly be blind. So that's a very important problem when we compare this treatment with a regular pharmacological treatment, because it's not a matter of a pill that can be completely disguised. If it's a placebo pill or a real pill. In this case, the agent knows very well what he's doing, and he knows that it's if it's a placebo treatment or it's a real treatment, because he's the one who is applying such a treatment. The second problem that arises from this tension is that acupuncture derives from a tradition that differs from contemporary biomedicine. And the implications are: point prescriptions do not necessarily follow a simple logic when analyzed in terms of contemporary biomedicine rationale. And that's very important, because our prescriptions can't be assembled and disassembled as could be understood by a simple analytic thought from the biomedical point of view. There is another logic that's behind that, an integrated logic. So reductionist adaptations make RCT acupuncture detached from real-life practice. Of course, if in our practice the prescriptions are adapted for every patient, every single patient, and when we make an RCT, our aim is to standardize such a treatment. Well, we have a problem here because we are being reductionist. So what is the point of investigating something that does not really reflect reality, the reality of acupuncture, the one that we practice in the day by day? Third problem is defining the object. What are the authors calling acupuncture? We know that acupuncture is an umbrella that means many different things. So do that particular paper is about, is that particular paper about single points, fixed points, using specific needling techniques, with the qi, without the qi, based on traditional Chinese medicine, Western style prescription, with manipulation, electrostimulation, trigger points needling. So what is being called acupuncture in this case? Because acupuncture is a vague word. When we look at the literature, so many different meanings it can have. And implications of that is that the demonstration of efficacy for a given acupuncture style do not grant the automatic generalization for any further given style. And that's very important, because when a systematic reviews and meta-analysis are made, they try to put everything together. And this is one of the main problems found in inconclusive systematic reviews on acupuncture, the attempt of putting together different objects to draw a single conclusion. It's not always assured. The fourth problem, the experimental controls involved in such trials, because there is not a modality of control treatment that can be thoroughly adequate in acupuncture clinical research. We know it's the basis of the RCT trials, the idea that we're going to use a controlled treatment that has only non-specific effects to be compared with a test treatment that has non-specific effects, and besides that, specific effects. And what we are looking for is the identification of the specific effects by subtraction. So when we look at acupuncture, we can see so many sources of non-specific effects and so many distortions that can happen during those trials that sometimes we can put in doubt the results we get. The non-specific effects in acupuncture include the whole ritual involved in appointment, the needling minus the pricking and penetrating with the needles, the prick sensation itself, except for the qi, and the non-specific needling, shallow or of the acupuncture. So we have many non-specific effects in acupuncture. So a clinical trial that's named controlled, when there is a control group set for comparison with the test group. Control is the point here that we're trying to establish. But as we can see, we have many problems to solve in order to get the control trial. The control trial has to have control groups that can be of several kinds. A test group before the intervention, that's the simplest kind of control, in which we start with a group, we apply an intervention, and we get some results after that. So we compare results after and before the intervention, and we can get the result of the intervention. The problem with such a control is we are not controlling the non-specific effects. We can have a control group that get no treatment. It's a waiting list. So in this case, we have two different groups. There is an intervention, and the other group is an waiting list. We compare what we get after the intervention, what we get with the waiting list, just following the natural course of the disease. So comparing those results, we can get the result of the intervention. In the case of acupuncture, as we saw, we have so many non-specific effects involving ritual and manipulation and the prick sensation, so many things that it's hard to compare with a group that is just in a waiting list, because we are not controlling for the specific effects. The next control group is the group receiving a standard treatment, a treatment that is recorded in the medical literature as being effective for treating a condition. In some cases, we cannot avoid using a standard intervention, for example. But a standard intervention can be compared. And in this case, acupuncture can be equal, inferior, or superior to the standard intervention. And so by comparison, we get the results. Depending on the standard intervention, of course, we can not control for the non-specific effects of acupuncture, because there is all the ritual and all the manipulation and the prick and everything. And so the last group, the last control group, is the group receiving placebo treatment. And in this case, we compare a placebo intervention that's considered inert with the intervention, in this case acupuncture, and try to get a conclusion about the efficacy of acupuncture. Placebo, theoretically, would have to reproduce all the non-specific effects. So it's everything that is in acupuncture except for the specific effects. And that's the very difficult point to achieve. In order to assure that there is blinding here, and blinding is very important in placebo studies, we have to have randomization of those groups. And supposedly would have a worse performance in the placebo group, a performance that indicates that acupuncture would be superior. Otherwise, there is no point to make this study. So there are several attempts of placebo treatments in acupuncture, like non-acupuncture needling. In this case, the needling occurs in other points that are not acupoints. Superficial needling, combination of both kinds, and this is commonly called sham acupuncture. And there is also the non-penetrating needling. And in this case, it's a false a needle that is used to reproduce what would be a real acupuncture needle in order to get really very close to the non-specific effects. Okay, but there are several problems here. One problem is this. Every time we try to approach, to make our acupuncture and placebo treatment closer, so for example, we include all the sensations possible except for the specific treatment, we, of course, are increasing our placebo, and the chance that we get an acupuncture effect that will be considered that's not effective is higher. And on the other hand, every time we get a placebo treatment that gets more different and avoid effects that can be acupuncture effects, we can get closer to the physiological inertness. So there is a tension here, a tension that involves blind inefficacy versus physiological inertness. So we have to get a treatment that's very close to acupuncture, but it's not close enough to be acupuncture. And that's very hard to get. And every time we have a placebo treatment that has specific effects, we are we have a defective placebo, a defective placebo that, when compared to real treatment, will create the illusion that the real treatment does not work. So there is another problem. The other problem is acupuncture is a kind of treatment that has a very augmented placebo effect, because all that environment and ritual and all those things. So we know that treatments that have a very large placebo effect tend to appear less effective when compared to treatments that less effective when compared with the placebo treatment itself, because there is a maximum that we have to reach. We can't go over a certain point. So the more elaborate is the ritual, the higher is the placebo effect, and that's the problem. So there are several attempts to create a non-penetrating needle that can be closer to a real needle. And we have here the three mostly used non-penetrating needles, the ones that are widely used in the literature of this kind. So you have the Streitberger device, the oldest one, the Park device, and the Takakura device. The Streitberger is the simplest one, and it consists of a needle that's like a magic knife, because the handle it slides. In fact, we have when we tap the needle, the handle slides, and it gives the impression that it really went into the skin, but it didn't. So we have the prick sensation, but the needle is not penetrating. This is, for comparison, the real needling penetrating. The Park device is the another one that's similar to to Strikeburger device, but with an improvement, because instead of a plastic cover as we have here, we have a sheath that protects the base of the needle, and it's glued by an adhesive to the skin, and when the needle is stepped, it pricks the skin, but it's not penetrating in comparison to the real needle.
Fernando, you have 3 more minutes.
Okay, thank you.
Thank you.
And this is the Takakura device. That's the only needle that allows blinding in this case, because it's not like a magic knife, but it has a foamy, a stuffing device that creates the illusion for the acupuncturist that there is that he or she is penetrating the skin. So the real needle really penetrates, but the blunt needle, it doesn't penetrate. It gets stuck here in the foam. And what we see from the meta-analysis of this kind of device is that in general, they do not support the notion that the Strikeburger and the Park devices are inert control, because there is effect. There is an effect associated to the use, and that's the problem. We have a needle that is not inert, so every acupuncture treatment that's compared to that will look like the veteran acupuncture, will look like non-effective. And we still don't have enough evidence to identify the best placebo device from those 3 devices. Maybe we will never. This is another kind of attempt to make a placebo treatment, that's phantom acupuncture, where the patient can't see what's going on with him, but he can see in a screen a video that's showing the application of needles. So he has the cognitive effect of the idea of that he's being treated, but he is not necessarily being treated. It's an attempt to reproduce the acupuncture needle ritual without the somatosensory tactile stimulation, but this is still in development. So the implication is, in acupuncture research, without pilot studies evaluating the performance of a given placebo treatment to be used in experimental control, there's no means to make sure that it will generate only non-specific effects. And a large amount of negative results from RCT literature in acupuncture may be generated by the use of inadequate placebo controls. So it's important to remind about the stricter recommendations that we have to describe very carefully the kind of control we are using, so this control can be analyzed and reproduced in other papers, so we can understand what's really going on. And finally, we get to the conclusions that the use of experimental controls in clinical research is not a closed issue, neither has a single answer. Every clinical trial has to take into consideration its particularities when choosing the experimental control to be used. And every study that employs experimental control must thoroughly describe the information about it in order to be able to validate its own results in comparison to medical literature. So thank you very much for your time.